Hi, everybody. Thank you so much for joining. My name is Rachel Krug. I'm the CEO of Virtual Field. Virtual Field is an exceptional eye exam experience for doctors, patients, and technicians. And today I have Dr. Robert Pearl on with us. He is the author of ChatGPT MD. It's a wonderful book, and today we're going to do a book discussion. Dr. Pearl, would you mind starting out by briefly introducing yourself?
Happy to do so, and thank you for having me today, Rachel. My name is Dr. Robert Pearl. I'm a reconstructive plastic surgeon focusing on children with cleft lip and cleft palate. I spent the first part of my career as an operative surgeon. I went on to become a CEO in Kaiser Permanente. I currently teach at the Stanford Graduate School of Medicine and Business. I have a weekly podcast called Fixing Healthcare. I write for Forbes. I consult to various organizations. And I want to point out that all the profits from the book ChatGPT MD, How AI Empowered Patients and Doctors Can Take Back Control of American Medicine, all the profits go to Doctors Without Borders, a wonderful charity.
That's great. Thank you for mentioning that. And to start out, could you tell us what inspired you to collaborate with ChatGPT for writing this book? And how did that process differ from traditional authorship?
Across my career, I've been a major proponent of a value-based medical healthcare system. I've written 3 books. My first book, called Mistreated, Why We Think We're Getting Good Healthcare, We're Usually Wrong, talked about all the systemic problems that everyone on this call today understand. They see it all the time in practice. And I point out the need for evolution to move from a fee-for-service type system of reimbursement, where the more you do, the more you get paid, to one that was value-based, a capitated system. I point out the need for more modern technology. The technology we use today is left over from the last century, although the fax machine, the most common way we communicate, is left over from the century before. It's an 1834 invention. I point out the fact that it's often fragmented care, with clinicians spread out across the community, unable to communicate with each other. And I expected that change would happen, and nothing occurred. And
Mhm.
so I asked myself why. As a professor at the business and medical school, I often ask the kind of Socratic questions. And I said, well, maybe the problem is the culture. So I researched that and wrote the second book on caring, how the culture of medicine kills doctors and patients. And again, I expected that change might happen now that I pointed out all of the blind spots that we have. Not that doctors don't work really hard or being very dedicated or very smart, they're excellent. It's just that we have blind spots because all of us are human, cognitive biases, but no change happened again. So once again, I asked, why is change not happening? And I came to the conclusion that we just have the tool to make it happen. It's one thing to get paid on fee for service, where you know the more you do, the more you get paid. You do 2 operations, you get paid twice as much as 1 operation. But a capitated system, that involves risk. And we need to be sure that we have the tools that were necessary, and they didn't exist. And then all of a sudden, we have generative AI, ChatGPT. And by the way, I have no connection to any of these companies. It's purely an academic type writing that I do. And I said, we have this. And then I looked at the technology and how fast it was evolving. It was exponentially doubling in power every year. That means that by 5 years, it'd be 30 times more powerful, 10 years, 1,000 times more powerful. You know, if our cars would be as fast as an airplane and then a rocket ship, we'd be taking action now. And I couldn't see a lot of action happening. But I also realized that if I wrote the traditional book, like my first two, it's a 2-year process. And by the time it was published, the technology would be totally different, it would be outdated. And so I decided that I would try a different way to write a book, which was with ChatGPT. And I approached it the way you would with a medical student or a resident writing a paper, back and forth versions, lots of different research. I fact checked everything that ChatGPT wrote. This was the 30-page bibliography. And I could find only one major problem, an hallucination, a creation of an exploration of the North Pole that I can't find any evidence actually happened. And it's a good reminder that the technology is not yet ready to be used in the ways that it will be very soon. But I also don't want us to lose sight of the fact that using it well as clinicians, we can save hundreds of thousands of lives every year and make medicine affordable for the American populace.
That's great. In what ways do you envision generative AI reducing medical errors and improving diagnostic accuracy? Can you share some real world examples?
The easiest way for most clinicians to understand it is in terms of our typical practice. And I want to point out that generative AI is very different than the other kinds of AI. We shouldn't just be talking about AI, we should talk about the different kinds that are there. But for clinicians, it allows us to obtain information immediately at no cost. I write in the book about a surgeon who was in the operating room, did a very complex um, neck operation, and knew that she had not hurt, not damaged any of the nerves to the larynx. And yet, at the end of the operation, the anesthesiologist said that the vocal cords were adducted close to each other, and that if the tube was removed, that the patient would end up having a respiratory problem, and wanted to know whether to transfer the patient to the ICU fully intubated. And so she took out her phone and went to ChatGPT, and she found several other cases where exactly the same thing had happened, not because damage had been done to any of the nerves to the larynx, but because the local anesthetic in some patients diffuses more. And in each case, the patient quickly recovered as soon as the anesthetic wore off. And so they waited in the operating room for 30 minutes, and all of a sudden, cords moved apart, and the patient could be extubated and sent home the same day. It's that opportunity that exists. There are 400,000 patients who die annually in the United States from misdiagnoses, and another 400,000 who are injured as a result, long-term disability as a result of a misdiagnosis. We know from the New England Journal of Medicine that 1 in 4 patients who die in a hospital or transferred to the ICU have had a misdiagnosis. It's just part of the nature of medicine. This is a second opinion that we can have. But the more significant parts to me actually relate to the way that this technology can help patients. And I don't want to call it medical error. I want to just say better diagnoses. You know, when I look at what's going on in American medicine today, particularly as I look at all of the burnout that's happening, my conclusion is doctors are just rushed too much. We have to see more and more patients every single day as reimbursements become more constrained. We're having to cut corners. And when that happens, errors occur. And when I ask, why is it happening now? My conclusion is that we're seeing a proliferation of chronic disease. And we haven't realized that when you see someone with right lower quadrant pain, it's appendicitis, you take out the appendix, you're all done. When you see someone with diabetes, you're going to see them 3 or 4 times a year for the rest of their life. That's a tremendous amount of added work. And we know that like 1/3 of Americans have or will have diabetes. And so I think that chronic disease and the proliferation of chronic disease is a major driver of, by the way, both healthcare costs, the fact that American life expectancy has languished, as well as the burnout that exists. You know, if you take hypertension, the number 1 cause of strokes, we control it only 55 to 60% of the time. If you look at diabetes, it's even worse. It's about 30% of the time. We know diabetes accounts leading cause of kidney failure, peripheral amputations, major contributor to heart disease. In fact, the CDC estimates that if we could control chronic disease, not perfectly, but to the best of knowledge today, 30 to 50% of heart attacks, strokes, kidney failure, cancer, peripheral amputations would go away. And try to imagine what that would be like, both in terms of the quality, the health of Americans, life expectancy, cost, if we could accomplish that. And this is where I think the tool can work, because we still have an episodic model of medicine. We see a patient in our office, we diagnose hypertension, we prescribe a medication, we say, I'll see you again in 4 months. What happens during that time? We don't know. And yet, colleagues of mine at the Stanford Engineering School have designed inexpensive, tiny Band-Aid sized wearable monitors. We could know what's going on. So why don't we ever use this? And the answer is because we have no way of evaluating that data. Let's say after a month, 100 readings have been taken. The patient looks at them, 92 of them are normal, 8 are abnormal. How's the patient doing? Are they doing great because 92 are normal? No, maybe they're doing badly because 8 are abnormal. The patient doesn't know, and no one as a clinician wants 100 blood pressure readings They don't want it clogging up their electronic health record. If all of a sudden a generative AI tool can analyze that, telling the patient how it is going, including within it the doctor's expectations for how the patient is going to respond, we could change the medication at 1 month, rechange it at 2 months and 3 months very easily, and reduce 40% of strokes. And when it comes to diabetes and other chronic diseases, the impact would be even greater.
Thank you for sharing the impact on chronic disease. Changing the topic slightly, given potential bias in AI data, how can we ensure that AI systems provide equitable and unbiased healthcare recommendations?
Let me go back to what I said earlier about the different kinds of AI. We put them together, but they're totally different. You have a narrow AI. This is the AI that has dominated medicine for the past 20 years. There's 600 applications that have been approved by the FDA. This is where we take, let's say, 10,000 mammograms, 5,000 of which show cancer, 5,000 of which are normal or have benign disease. And then the AI application using neural nets and deep learning figures out 50, 60, 100 differences, slight differences between these two data sets. And doing that, it can predict and define which patients are likely to have cancer, and to be able to tell that to the clinician with outcomes that are 10% better than radiologists today. What's the problem with narrow AI? The problem with a narrow AI tool is that it's narrow. You can't use the mammogram application to be able to do even chest x-rays, to say nothing about brain scans. Generative AI is completely different. There we preload all the information from the internet, every medical article, every textbook. Soon we'll have all the information coming out of medical meetings, and using that with some parameters, over 1 billion parameters that have been put in about which data is most important. Articles that are more recent are more important than past articles. Articles that are peer reviewed are more important than ones that are not. Ones from leading academic institutions are more important than ones that are simply individuals posting information in some type of online journal. And then it's able to answer any question. Now, let's go back to this narrow AI. What is narrow AI's biggest problem? It's the data sets that are submitted. And this came to a head maybe close to a decade ago, when a tool designed by United Healthcare to identify the sickest patients in their population for a good reason, in order to give them more resources, found about 15% of the people selected were Black patients. Independent researchers came in there, and they used the AI to find that group. Independent researchers then came in and said it should have been closer to 50%. What happened? Well, the application comparing the data sets ended up using the cost of care provided as a measure of severity of disease. That makes logical sense. If we give more care, patients should be sicker. The problem is that in American medicine, Black patients with identical symptoms to white patients get $1,800 less medical care. And you may remember during COVID, when there was a shortage of testing kits, even though the mortality among Black patients was twice as high as white patients, Black patients got tested half as often with exactly the same symptoms. And the literature is filled with this type of bias. I discuss it in great detail in my book on caring. But that's a narrow AI tool. It's not that the tool is biased. It's that it's reflecting what goes on in American medicine. It's no worse. It's just more obvious when it comes to an AI application. And it's why I have some actually optimism. Because in a generative AI tool, you can tell the tool, make certain this is not biased. And the tool has been updated in all the literature on bias. It's seen the chapters in various textbooks on the problems that Black patients have, or whatever group you're looking at. Because of the practice of medicine, it doesn't replicate it. If you task the technology in generative AI, tell me what the typical white 40-year-old doctor will do, you're going to get a biased answer. If you tell the tool, give me the information that that is unbiased, you're going to get a different answer. And why I think this could be so powerful. Let's look at maternal mortality. The US maternal mortality amongst Black patients is 8 times higher than any other nation in the wealthy part of the world in our peer nations. And why does that happen? It's going to be a bias. A Black patient having bleeding, rather than calling the attending physician, the nurse is likely to wait longer. Or a patient who has early hypertension, the nurse is likely to wait longer before calling the attending physician, before making the intervention and the change and the postpartum period. Speed to intervention is key. Well, this technology can update people, can point out to the nurse you would normally call the attending physician in this situation. Or we know that clinicians after operative procedures give 30% less pain medication to Black patients. It can point out you're prescribing less medication than you usually do. Now, there may be a reason why. Maybe there's something about the patient that makes a higher dose of a narcotic inappropriate, but it can point out that variation. And in that way, actually, I'm hopeful that a generative AI tool will be an anti-bias, not a pro-bias, as some of the other narrow AI tools have been.
That's helpful to understand how it could augment understanding and catch some of these unconscious biases. We have time for probably one more question. So I'm curious, your book discusses the democratization of medical knowledge through AI. How do you think this will change the patient-doctor relationship? Particularly, you're describing a doctor going to ChatGPT, but presumably a patient could also go and look up information.
Well, if the participants in this conference today want more information, they go to my website, robertpearlmd.com, where I have a lot of information on this topic. But I do believe this will be a massive change when it comes to empowering patients. That's why I have that in the subtitle of the book, ChatGPT MD, because patients can put information into place. I was on a podcast about 3 weeks ago, and the host of the show at the end, after we signed off, said, Dr. Pearl, you're a skier and you're a medical expert. My husband fell while skiing. His arm was over his head. He slid down about 100 feet. And his shoulder now, several months later, 3 months later, still hurts. And he can't use it as well as the opposite side. What do you think is going on? I said, I think I know what's happening. But you've never used ChatGPT. Why don't you go put all the information you've given me into the application and see what information it provides for you. And then give me a call back and I'll tell you what I think. 5 days later, she connected back with me. She said, Dr. Pearl, thank you so much. I put all the information into the application and it said the most likely diagnosis was a torn rotator cuff, that my husband would need an MRI, and most likely it should see an orthopedic surgeon because most likely he needed surgery. Now compare that to a Google search. This is completely different. Instead of getting a whole bunch of links or being just told go see an orthopedic surgeon because that's the safest recommendation you can make, it's very specific. When they went to the clinician, they understood what the doctor was saying. And she told me that he said it's probably a torn rotator cuff, ordered the MRI, did the surgery, and at the end said, had you waited a few more months, I might not have been able to reattach that torn rotator cuff muscle because it would have contracted. That is the difference that is there. I was at a conference presenting at Stanford to a bunch of CEOs, and one of them came up to me at the end, and he said, my daughter had a very difficult problem, major symptoms sitting in place. It took me 18 months to make a diagnosis by going to a variety of academic centers. It was a very complex chronic inflammatory disease. And while I was sitting there listening to you, I put all the information into the application and it gave me the differential diagnosis. At the top of it was the exact diagnosis. This is the future. Patients will use it, they will become educated. And when they come to the clinician's office, they'll understand their problems far better. Not like today when they bring a 100-page Google printout search. No, they're actually going to have expertise. They'll know the most likely diagnosis. They'll understand why it's being made. And I think it actually will augment the doctor-patient relationship. I think clinicians will be able to achieve better outcomes with patients. And ultimately, why do we all go into medicine in the first place? Because we want to make patients better. We wanted to improve health. I think tools that allow us to do that more reliably and more effectively will actually increase our satisfaction as providing clinicians and be able to improve our relationship with our patients. And to the extent that it generates more time, it will get us off of the current treadmill. We're having to run faster and faster, seeing patients every 17 minutes, never able to have the kind of deep personal relationship that we would like to have. And I think the future in that way is going to be bright. And if together we can use it, we can make American medicine, I believe, once again, the best in the world.
Awesome. Well, thank you for that. That was a very beautiful conclusion and sentiment. We appreciate your time. Thank you for your insights. And thanks everybody for joining. We're going to conclude for today, and I'll see you next time.
Thank
Bye.
you so much.